All right, let's call this meeting to order. The first agenda item is approval of the minutes. Included in your packets are copies of the minutes from the April 17th public meeting of the Commission. If there are no changes or corrections, I will entertain a motion for approval. Second. Any discussion? All in favor? Aye. Any opposed? Next agenda item is update of the activities. Commissioners, you've received the written updates from our centers. Ben, do you or any center directors have anything you'd like to add?
Thank you, Mr. Chairman. I wanted to note that the commissioners get a copy of the update of activities. It's appropriate if you have questions to call out now. We are looking at updating how that update of activities needs to be re-engineered to shorten it and make it more concise. And if you have ideas, please feel free to provide those. Secondly, as the commissioners know, we have been participating, having staff participate in some work groups that HSCRC has been convening over the past several months on activities related to the waiver, payment models, the data infrastructure, quality reporting, and delivery system reform. As appropriate, I'll ask Commission staff that are attending those on behalf of the Commission to provide information on what we are doing, to provide brief updates during the update portion of the Commission meeting. Clearly, before we make any commitments to HSCRC, we will be coming back and seeking your input first before we commit Commission resources or perspective going forward.
So, good afternoon, Mr. Chairman, members of the Commission. On May 7th, staff convened the Patient-Centered Medical Home Practice Transformation Work Group, which consists of payers, providers, and other stakeholders, to identify opportunities for advancing integrated models of care delivery after the Maryland multi-payer PCMH program legislation abrogates at the end of 2015. During the work group meeting, participants discussed what they considered to be key attributes for models of advanced primary care, and commercial carriers provided an update on the implementation of their innovative care delivery models in Maryland and nationally. The work group is planning to meet about 3 times over the summer to formulate recommendations to enhance integrated care delivery models. At the upcoming June 3rd meeting, the work group is planning to discuss a framework for evaluating integrated care delivery models, consistency in care management activities across programs, and opportunities to standardize select carrier data. As part of the Maryland multi-payer PCMH program, the MHCC engaged the University of Maryland Department of Family and Community Medicine at the University of Maryland. The MLC consists of about a handful of members which provide guidance to roughly 52 practices and guidance around knowledge, information, and collaborative experiences to achieve and maintain patient-centered care and to overcome challenges with practice transformation. About twice a year, the Maryland Learning Collaborative convenes a day-long conference for MMPP participants. The first conference of the year is scheduled for next Wednesday, May 21st. The agenda includes about 8 presentations and network opportunities. We have about 135 attendees confirmed for now, and if there are any interest among commissioners to take part in this event, we encourage you to do so, staff does, and if you'd like contact information about registering, feel free to reach out to me or to Melanie Cavalier, who is behind me to my right. Mr. Chairman, this concludes my addition to the update.
Thank you. Thank you, David. If I could just ask, perhaps you could circulate the agenda for that meeting to the commissioners.
Got it.
That's request number 1. And then a question. if this work group is contemplating looking at innovation in workforce such as community health workers, and I know there's going to be some work this summer on that in a separate task force. Does that intersect at all with what you see the future of this primary care work group being?
So this is a great question. The first phase of the work group was really to bring together stakeholders to talk about what does the model of PCMH evolve to. It is an evolving landscape, evolving term. In the future, what does it consist of? Because we have PCMH, we have ACOs, we have the STEM model. Yeah, there's so much going on. We want to be able to look at what is really needed to sort of keep at the glue to hold all these initiatives together. What we're hearing, things about data that's significant, standardized, streamlined data, having more consistency around what does care management look like. Other information about evaluation and reporting. You know, what is necessary to create an environment of transparency, plus provide a great education around key elements to report on out of these integrated care delivery models.
Okay, I would just add that personnel, provider pathways.
Very good. Thank you for your feedback. Thank you.
Other questions? Aaron?
Thank you, Mr. Chair, fellow commissioners. I know you just heard from me last month wrapping up the 2014 legislative session, but we're already looking forward to the 2015 legislative session. The Office of Governmental Affairs at the Department recently sent out a timeline for next session's departmental legislation, and we are currently working on pre-proposal concepts with the Department on a number of initiatives, including a statutory increase on MHCC's assessment cap. These pre-proposal concepts will be submitted to OGA by the end of the month, and full legislative proposals will be submitted to the Department in early July for review and submission to the Governor's Office in September. After that, MHCC staff gets a list of all proposed departmental legislation in early fall, and we can comment on other departments' legislation going into the winter before anything is introduced. So I just wanted to update you all on that, and you probably won't hear from me for a couple of months, but that's what we're working on. Any questions? Great. Thank you.
We'll move on to agenda item number 3. The Commission approved proposed replacement regulations, COMAR 10.25.16 electronic health record incentives at the January meeting. The replacement regulations align the requirements for primary care practices to receive an EHR adoption incentive from state-regulated carriers with the Federal Electronic Health Records Incentive Program requirement. Angela Evat, Chief of the Health Information Exchange, will present the proposed replacement regulations as final. Angela?
Thank you, Commissioner. Good morning, good afternoon. I'll be presenting on final action for COMAR 10.25.16. In terms of a little background, I'm sure you're all familiar with our state payer incentive program. The regulations that created the program went into effect in 2011. There was a law that passed in 2009 that required us to require state-regulated payers to provide an incentive to providers for the adoption and certain use of electronic health records. The state incentive program makes available to primary care practices a base incentive of $8 per member up to $2,500 for the adoption of a certified EHR, and an additional incentive of up to $7,500 per payer is available to primary practices under the old program. Some changes that will occur for the new program we'll cover in just a moment. In 2011, a law was created that required us to study or to amend the law to study the incentive program. We released a report in January 2013 under House Bill 736, which indicated that we needed additional time to understand the impact of the program. In the summer of 2013, leadership from the Maryland General Assembly asked us to continue with that evaluation. At that time, the staff concluded that the incentive program hadn't had the impact that we hoped to advance the use and adoption of EHRs. We convened stakeholders to amend the regulations, and some of those key changes you have seen in our January meeting, which included changing the qualifications around the EHR incentive payment. Under the new program, physicians and nurse practitioners that are within a primary care practice that have attested to meaningful use could qualify for a state incentive program. Or, alternately, a primary care practice that has participated in an MHCC-approved PCMH program and has achieved NCQA Level 2 recognition could also qualify for EHR incentive program underneath the state. We also expanded eligibility, thanks to the leadership here on the Commission, to primary practices led by a nurse practitioner. And we removed the additional incentive component of the program, and rather than $8 per member, we've upped that to $25 per member. However, the maximum amount of incentive will stay the same, capped at $15,000. During the comment period, we received one letter of support from our stakeholder, the Maryland State Medical Society, or MedTide, which you should have in front of you in your attachment. So in terms of next steps, staff recommends that the regulation be adopted by the Commission as final, with one non-substantive change, which is included in your packet. This change just aligns the current regulation with the law, which was amended in 2011. If adopted by the Commission, staff plans to provide guidance to our stakeholders, such as the payers and MedCai, and implementation of the program. I want to note that there is in the regulation a 120-day implementation period for payers to create the administrative changes within their systems to begin accepting applications under the new program. So if adopted as final, my understanding that the regulations would probably take effect around June, which then providers could then apply in October. In an effort to increase awareness about the program and participation in the program, staff plans to target outreach to primary care practices that have or plan to achieve meaningful use of, have achieved NCQA recognition level 2 at least. In our estimation of the data that we have currently in terms of participation in the current program and meaningful use, we estimate there are about 990 primary care practices that haven't received an incentive underneath a state program, but have either registered or received a meaningful use payment under the federal program. So we plan on targeting those, as well as the practices we know have achieved level 2 or greater NCQA recognition. So that concludes my presentation, and I will take questions if you have any.
Any questions or comments? I'll entertain a motion to adopt the final regulation of the electronic health record incentive. Second? All in favor? Any opposed?
Abstain.
One abstention. Motion carries.
Thank you.
Next agenda item is a certificate of need for Mercy Medical Center. Mercy Medical Center seeks a modification of its previously approved CON to relocate 4 operating rooms and add 4 additional operating rooms. Joel Ricklin, Program Manager, will present the staff recommendation. Joel?
Commissioners, the modification request you have before you is the request of Mercy Medical Center for approval of a capital cost increase for a project first approved in December 2012. As some of you may remember, the project involves finishing a shell space for the relocation of 4 operating rooms from the Weinberg Center and the addition of 4 operating rooms to the hospital's capacity. The shell space is on the first floor of the recently opened Bunting Center, the hospital's new patient care tower. The total approved cost of the project was $23,529,000 $589. The approval included one condition excluding a small portion of the cost from inclusion in any future requests for rate adjustments associated with this project, because the estimated construction costs at that time exceeded Marsh evaluation benchmark for comparable construction. The requested modification is approximately an increase of $1.8 million in total project costs to $25,381,424. Mercy pointed to the need to add an air handling unit that drove other changes, design changes, and changes in architectural and engineering fees. The requested increase in project costs also includes an increase in the amount budgeted for future inflation. Mercy attributes this increase to an error in the calculation of the original amount of future inflation and an increase in projected rate of inflation to the midpoint of construction based on the new project timeframe. Commission staff developed a new Marsh evaluation benchmark for the revised project design and determined that the current estimated cost is now below this new benchmark. Thus, the condition limiting the size of any future increase in hospital rates or budget is no longer required. Staff recommends that the Commission approve the proposed modification because the increase in cost has no effect on previous conclusions regarding the need for the project, the cost effectiveness of the project compared to alternatives, or its impact on existing providers. And as pointed out in the HSCRC comments, Mercy has sufficient funds to implement the project at the higher cost. At this time, I'd be pleased to answer any questions. Also available to answer questions representing the hospital are Judy Whalen, Senior Vice President for Strategic Capital Planning, Kathy Pinkleton, Senior Director Financial Planning, and the Hospital's Counsel, Tom Game.
Questions or comments? I guess I have two. Just in terms of how often do you see these type of error adjustments? So it seems like one of them is just sort of pretty technical.
You mean they're talking about the future inflation?
Yeah.
I don't think we see too many in the future in budgeted amounts for future inflation. If anything, actually, they tend to go down when people come back from cost increases.
And then, can you comment on the in the details? There's an allusion to sort of HSCRC's let's see, what does it say? Staff concern with the use of limited resources to add 4 operating rooms given the transition. Can you comment on HSCRC?
Well, I think HSCRC is obviously concerned under the new payment model with any increases and the view that volumes in general might decrease. Mm-hmm. So I think that's as well as I can speak for their perspective on it. They're just telling the hospital that they should be careful about they should carefully consider their expansion plan. I don't think this would change what they're doing. They can address that more. Maybe they might look at it again and say, oh, we only need to add 3 ORs and not 4, which would be a minimal change. Shelf space 1 wouldn't change the analysis of the cost effectiveness of alternatives.
And what is staff's perspective about the needs and the capacity? Has anything sort of changed, with the old analysis, versus the new environment?
Well, we haven't done a new, because we don't think this doesn't directly affect the utilization. We didn't do a new evaluation of that, and we didn't think it warranted a new evaluation of the need. And I think we're really in the early stages of the impact of the new payment model. It would be difficult to see what they'll do. But the hospital is actually, their implementation phase, I think, runs a good year before, I think it's a little more than a year before this project is actually done.
Yeah, I was just going to ask Joel to comment on the surgical capacity in the city and county generally, if you could provide some, recognizing that this is a minor adjustment, but in terms of this, what is the surgical capacity in the city, you have any comments on that to share with us?
Not in, yeah, I know that the HSCRC made a general comment about excess capacity, and I'm not, haven't looked at any general Baltimore area. In terms of the hospital, we did look at it when, in the initial review, they're going from, I think, 22 to 24 ORs in total, and we found that they would have a need for it in a reasonable period of time.
Any other comments? Questions? Okay. I'll entertain a motion to approve the CON. Moved. Second. All in favor? Any opposed? Any abstentions? You have your approved CON. Thank you. Next agenda item is a Certificate of Need exemption. MedStar Health System applied for a Certificate of Need to relocate a freestanding ambulatory surgical facility, the temporarily de-licensed Surgery Center of Pasadena, to the planned MedStar Brandywine Health Center, an outpatient facility to be located in Prince George's County. Kevin McDonald, Chief of Certificate of Need, will present the staff recommendation.
Thank you and good afternoon. MedStar temporarily de-licensed this 3-room ambulatory surgery center in Pasadena and Anne Arundel County in November of 2012. As required, within 11 months, they notified the Commission of their intention to relocate the center to a site in Brandywine, Prince George's County. That site is approximately 5 miles from Southern Maryland, MedStar Southern Maryland Hospital Center. The controlling regulation in this case is 1024-0104A2, which allows the relocation of an existing healthcare facility owned by a merged asset system to be exempted from Certificate of Need if it meets certain conditions. Those conditions being the relocation is within the primary service area of the original facility to be relocated, or within the primary service area of the merged asset system, and that the relocation does not change the type or scope of services offered, which it doesn't in this case, and does not require a capital expenditure for construction that exceeds the capital review threshold. The current threshold is $5.9 million for this kind of facility, and the estimated cost for the ambulatory surgery center portion of a larger project is $5.347 million. The regulations direct the Commission to issue an exemption for the CON if the Commission finds that the proposed action is within the public interest, is not inconsistent with the state health plan, and will result in a more efficient and effective delivery of health services. Staff's assessment of those conditions are, starting with the public interest, that there is a potential for lower costs in an ambulatory surgery center than would be experienced in a hospital-based ambulatory surgery because of lower overhead costs primarily. Also that services delivered in an outpatient basis like this would be more convenient and less stressful for patients than would be so on a general hospital campus. And also that it would facilitate MedStar's ability to increase the number of surgical specialists in southern Prince George's County. On the consistency with the state health plan, we found that the volume of outpatient surgery already being performed in this market at the MedStar General Hospital, as well as projections for this facility, provide a reasonable basis for concluding that the 2 proposed operating rooms would operate within the definition of optimal capacity that exists in the state health plan. However, we do believe that the addition of this MedStar OR capacity in this market, where the current general hospital operating rooms are underutilized at this point in time, will raise the burden of proof in MedStar's pending CON application to justify its need to maintain all of the existing surgical capacity as is being proposed in that Certificate of Need. On the third condition, that being that this will result in more efficient and effective delivery of health services, very similar to our finding on the public interest item. We believe that it's likely to benefit the healthcare system with lower costs and a more convenient setting for patients, and that it certainly could facilitate MedStar's efforts to attract more physicians to the southern Prince George's market. As noted, however, authorizing the relocation of operating capacity does raise issues with respect to the ultimate efficiency of the overall inventory and configuration of surgical services that MedStar ultimately has planned for this area. However, that will be addressed in a future decision on the hospital's expansion and renovation project, which is currently under review. With us today from MedStar, Patricia Cameron, Senior Policy Analyst in Government Affairs, Jill Johnson, Assistant Vice President, Physician and Ambulatory Care Planning, Ashley Provost, Corporate Counsel, and Pegeen Townsend, Vice President for Government Affairs.
Any questions or comments?
Just one question. Has there been any discussion with MedStar about the expansion in Southern Maryland, about whether they would accept your opinion about what should be done, given that once this is approved, would they be willing to modify their other proposal? Or and I'm only mentioning this because we've had this ongoing discussion about front-loading these kinds of things rather than at the end coming down with these decisions.
That discussion hasn't occurred yet. In terms of this completeness review for the CON, that is one of the key areas of that's sort of remaining open for gathering the amount of information that we need.
So it's still in completeness review right now?
It's still in completeness review at this point.
So it could be discussed at this point?
Certainly could.
Just a question. Why would the facility in Brandywine be more attractive for physicians than in Anne Arundel County? Just want to know. That's what I think I heard you say.
So your question is, why would the facility be more attractive in Brandywine than in Anne Arundel? I think I would like to have MedStar address this, but I think from what I know of from the materials that we've received, essentially, well, first of all, it's two very different market areas. I don't believe they have a hospital that is close to the facility in Pasadena, so I think there's more synergies by being able to, because in the CON application for Southern Maryland, a big part of their planning there is to be able to retain more Prince George's County patients by bringing in a number of specialists. And I think there will be a lot of synergy between these two initiatives. But I certainly would suggest that they be given the opportunity to address that if they would like.
Step up if you can to the microphone.
Actually, I think Kevin summed it up pretty well, but just Jill Johnson. The two markets are very different. The facility that we're replacing, that we shut down in Pasadena, was quite old. The location was a little difficult to access. The facility was much larger than we needed it to be. When we decided to shut that down, the market in Brandywine, as you had surmised, is very attractive to us. It is closer to an inpatient facility that we own. The facility itself, part of our assumptions that you've read, this facility will be predominantly orthopedic, and we have a large new orthopedic partner that's joined the MedStar system that these operating rooms will serve.
Other questions? John?
So does Pasadena and Brandywine aren't very close together. So does that now leave a hole in Pasadena, shutting that down? Because I know the report says it's now going to be more cost-effective, convenient and all, but it's not really for those people at Pasadena.
No, it's not. Those physicians relocated back to MedStar Harbor Hospital over a year ago. So that market, we haven't been there for quite some time now. Mr. Chair.
Yeah.
So just to follow up on that, is there an ambulatory surgical center in the service area that is Harbor Hospital in the northern part of Anne Arundel, southern Baltimore City area? Not that we own, no. They do have ambulatory services at Mentor Harbor. Right, but not freestanding, not freestanding. So there's I know from looking a year ago at the cost differential in terms of a routine screening colonoscopy, the difference in what the cost is in a freestanding center versus in a hospital, and it's orders of magnitude different with very, very similar outcomes. A lot of the public health screening activity, and Harbor has been a partner in that, has really relied on maximizing the number of screens because the resources available to funding is fixed. So to follow up on Commissioner Fleck's question, does this leave a hole in terms of access to freestanding ambulatory surgical screening services in the northern part of the county or southern Baltimore City? My understanding is shortly after we vacated that building, Anne Arundel Medical Center moved in. So I don't think there's going to be a service gap in that particular market. With a freestanding, with a surgical center? I can't speak to whether they intend to come and request that they reopen those ORs, but they're physically still there. Are you aware of that?
Not aware of it.
Thank you. We didn't demolish them when we left.
Kevin, this is a question for you, but let me just clarify, and then we'll go to Glenn. So my perspective is these are almost two separate business decisions. They're kind of because they're really affecting two different populations, and they're not really that fungible. But from the commission rules, basically they get connected together.
right, so I think we've got the all clear. So what we're going to do today is all the team members here, we're going to present sort of the picture as a whole in parts. I think the first to note is that the medical care database has been a vital tool in understanding pricing information for quite some time. And this has taken the form of a broader report in the past, and we're going to present a portion of that report called the Professional Services Report today. And so what that static sort of report may no longer be really needed in the advent of sort of a web application that might be able to investigate it and give people more ready access and timely access to the data. So we'll give you a brief background on that, and then subsequent to that, we'll actually present on further developments of the web pricing application that you saw last time, which was in response to CMS also releasing procedure-level pricing information for providers, and our development of an application to show Medicare and private carrier data together. So you'll be getting a chance to take a look at that as well. And one of the thoughts, as was mentioned, is that we want to have you think about at least the notion of the web application maybe being an adequate substitute for this report going forward, which, mind you, is a legislatively mandated requirement for the Commission. So a quick background on what this report has entailed in the past. It used to have one portion which looked at sort of the per capita expenditures by users, plan types, and payer characteristics, and looked at annual variations. This we now call the privately insured report, and it has been moved to a separate item, which we have presented to you in the past as well. The second component was looking at provider pricing, and looking at one important thing was normalizing the pricing with relative value units. So that's sort of the portion that we're talking about here today in the presentation. And this has been also, again, an annual report showing some changes year on year, and looked at market share, provider characteristics, and in more recent years looked at comparisons to Medicare and Medicaid pricing to give you a sense of how private insurance stacked up. One area that had been considered for a long time is specialty and how pricing might vary by specialty. But that hasn't been done in the past, but as you'll probably see with the application forthcoming, that some of that might be more readily doable in the application environment. So a quick overview of the professional services report as it stands. So it's based on the 2012 MCDB data, and for the Medicaid and Medicare data, it's really based on the fee schedules for the comparable services that might be rendered. The overall payment rates, as we find, is relatively stable, with just a marginal increase from $36.11 to $36.49. This is payment per RVU, not for services, of course. Large payers, as has been the pattern in the past, have pay about 12% less than other payers. This is due primarily to their market share and power to negotiate. Out-of-network payments, again, are almost double that, or a little over double that of in-network payments for services as a whole. The rate. Sorry, yep, the rate, not total necessarily. And then the other thing that we will highlight today is that the private insurance payments are roughly equivalent to that. The rate is roughly equivalent to that of Medicare payments, and about 30% higher than Medicaid. So we're going to focus on just showing you quick snapshots of these, and then move you on to the demonstration of the web application and discussion, which Linda and Leslie will lead those portions. So this gives you a quick overview of the overall payment rates by payer market share. So as I mentioned, the large payers, both in 2011 and 2012, you'll see have paid about the 12% less, as I mentioned, in payment rate as a whole. If we break this down into in-network and out-of-network, again, you'll see the jump in payments to out-of-network, the payment rates. I will mention to you, there is another report that will be forthcoming that really will investigate the out-of-network payments and the assignment of benefits report that is expected later this year. So you'll get some more details about that in response to legislation related to assignment of benefits. That isn't a focus of this report. But again, as I mentioned, we have about double the payment rate in the out-of-network. And then finally, when you compare to Medicare payments, whether in large payers or other payers, they're roughly equivalent, again, with other payers paying slightly more. And Medicaid as well, we have about 30% increase overall compared to Medicaid payment rates in the private insurance market, with, again, the same sort of large payers paying slightly less than other payers. So that's a quick brief overview of what's in the report. We have often explored some other items, but this is to give you sort of the monitoring, what's happening with that. And with that, I'll turn it over to.
I think there might be some.
Oh, okay.
Question?
So that has traditionally been the two largest payers by volume of patients, by volume of members, has been the large payer grouping versus other payers. Including self-funded. And it includes all, and I should also highlight that while in the privately insured report that you've seen in the past where per capita expenditures are calculated, that focuses on full-year enrollees. This includes all enrollees in this calculation.
So just to give it a bit more context, that the format for this report has been pretty static for about 6 or 7 years, and the outgrowth of it really was driven by 2 factors. One, internal, and the second, external. One, we were trying to make this report more industry focused. Secondly, there was enormous interest in Maryland on payment adequacy, consistent with the methodologies used by MedPAC, the Medicare Payment Advisory Commission. We begin to apply some consistent approaches for assessing payment adequacy consistent with what the legislature had asked us to do. I think we see now a change in the environment, payment adequacy, as we see a move to new delivery models, new forms of payment is not as compelling for practitioners as it once was, in the form of how does fee-for-service stack up, given that payment flows are coming from shared savings, incentive payments, and other issues. Actually, the fee-for-service arena is just but one of several payments that we can get. And we're also seeing a diminishing sort of level of animosity between practitioners and payers, that rather than adversaries, they are increasingly seeing themselves as collaborators. Tension still exists, but the opportunities for collaboration are developing. I think Srinivas and Linda have correctly gauged the interest that's diminishing right now.
I don't know if you said this before, but what percentage of total payments do the large payers represent?
60 or 70%, I think. Is that about right?
Mm-hmm. So it's a huge chunk.
Huge.
It's the majority, yeah.
Going to the next agenda item. Okay. Based on Commissioner's suggestions made at the April meeting, staff has worked to add additional functionalities to the provider pricing web application, such as permitting provider comparison and options for filtering data. As noted earlier, staff believes this application can substitute for the professional services report. Staff wants to get feedback and make the application available to commissioners and members of the Practitioner Performance Measurement Work Group for further review and comment after today's commission meeting.
Thank you, Mr. Chairman. It's in order to put a context on this presentation, I wanted to let you know where we stand with our public web portals. As you know, we currently have one portal, but we are going to move to adopting a CMS style of sort of parallel portals. So there will be an industry portal, just like CMS has, and then a consumer portal, which is a separate portal. And that's Medicare.gov. I don't know if you've ever been to the Medicare.gov, which is really focused on what a Medicare enrollee would want to know. And then you can go to the regular CMS website, which is where the the industry goes, for far more detailed information, for all manner of things that have to do with how CMS conducts its business. So our industry portal will be our current website. It will continue to have our information that's focused principally on policymakers, industry representatives, researchers. And then we are going to be improving this website. We have plans to redesign for easier navigation. We're going to be moving to a different software that will make it easier for us to navigate. We've been working under sort of a mandate to use a certain DHMH software, which has given us very limited ability to structure the pages in ways that people would find useful. I think you'll really enjoy the new website. We'll get information from you back after you had a chance to, it's been employed and you can use it. We will also, in the future, have a consumer portal. All the consumer-oriented web pages will be accessed through this one portal. And on the main page, there will be a button that says Consumer Portal. And you'll hit the consumer, but it won't say portal. It'll say something user-friendly. But you'll click on it, and there you will be able to choose among all our consumer options that we currently have, such as the long-term care guide and the hospital guide. So, and then additional things that we would do around consumer pricing and other kinds of consumer information will also appear in the new portal. And that will, it will limit the information to just what interests consumers, because we know from research that you don't have very long to get their attention. They either go, oh, this isn't for me, and move on, or they think, oh, yes, it is, and we'll include all that context information that consumers need, which is, why would this matter to me, and how can I use this information?
Okay.
So we're going to move on to presenting the industry portal. Our industry portal has, for this medical web application, has two separate windows. There's a provider search window, and there's a procedure search window. And last time we were here, you saw the provider search window. And Leslie has made many lovely adjustments to that, and she's going to outline that for you today.
Okay. So last month, when we showed you this application, you could select on the provider name, the specialty, and the location, entering either a city or a zip code. Larger?
That's a little large.
And since that time, we've added the ability to select on county, and we've also added a selector on procedure grouping. The procedure grouping is based on the clinical classification software from AHRQ. And I wanted to talk a little bit about some data caveats right off the bat before proceeding. Most importantly, this data is a subset of all the data that we have, and part of the reason we wanted to be able to get your feedback on primarily usability, how you want to slice and dice the data while we're working on numerous data challenges. It just makes the process more efficient. The payments are based on our 2012 professional services file. Because we needed some level of consistency in order to present the private records beside the private payments besides Medicare, we needed consistency in specialty and location. So this subset is based on MPIs that were available in the private side that we could map to the Medicare file. And keep in mind when looking at payments that they are influenced by how the service was coded with the NPI. There are numerous issues around one person or one NPI being attributable to a number of services that are actually provided by other providers.
So this would be like type of caveats that if it's out available to the public that we want to highlight, that we want to be cautious about. You probably don't need to go through every single one.
Right, and we wanted you to understand that every physician won't be in there. The only physicians who are in there are the physicians who exist in the Medicare database, and we added their private information. So it's that. If you look up someone who doesn't treat Medicare patients, they won't be in the data.
And among other data exclusions are removal of out-of-network payments, missing or invalid NPI or zip codes, non-Maryland practice locations, routine dental services. You see the list here. This is available when you go to the application. You just click on the button. And private payments were calculated after dropping payments for consumer-directed health plans or out-of-network payments. However, the service totals and the patient totals were counted regardless of those exclusions. The Medicare public use file only provides payment means. So we did a calculation for the payments that we present for Medicare by weighting by the service count. Okay. So I'll go to the provider view. So I'm going to, just to start off with, I'm going to select on the procedure grouping. I find this easiest. So the first table that you see is a selector table, and you can select one or more providers from this table.
So these are all physicians who performed coronary artery bypass surgery.
Correct. And the totals table that you see will always be consistent. It will always show the totals for patient services and payments for private and Medicare for all services provided in the state. However, the second table that you see, which shows you the individual procedures, will be influenced by your selectors at the top. Primarily the procedure grouping. If I had not selected by the procedure grouping.
Leslie, if I ask you to select all,
sure.
Because I think one of the things that we're seeing is that the two that you selected
there you go.
have no Medicare, I have no private payment. This is probably a data anomaly yet.
Okay.
Thank you.
So we selected all. And again, you will see all procedures for that procedure grouping in the procedure table. Now, for example, just to show you how the procedure table is influenced by your selection. Let's see, I'm going to take, let's take a different thing. If I wanted to,
so as in this example, Medicare is clearly the dominant payer for these procedures, so having the private insurance data adds some information, but probably doesn't change the answer that you get from Medicare only. As you guys have been looking through this, there's sets of procedures, their provider views. You know, obviously, the younger the population, you're going to get more complete views. Any initial perspectives on
I think one thing
what
that
questions adding private insurance will better answer?
Well, one important thing is Medicare data, especially like if you wanted to look for pediatrics-related items, that Medicare isn't really going to provide you the appropriate data. So I think there are sort of subsets where you'll find better information. In terms of overall payment volume, obviously Medicare is going to be high for a lot of areas, but I think having the comparison is useful. And also, I think the other thing to note is that, this is probably a sort of foreshadowing to the consumer side when we get to that portion. But I think if you're looking for a provider to do some procedure and you're interested in perhaps how with their proficiency and how often they've done it, and so adding up counts of, say, private and Medicare makes a big difference, and that's helpful as well. And you'll get a sense of the price variation that way too, or choosing who to go with.
Yeah.
Okay, right. So here's a cancer chemotherapy, right?
Mm-hmm.
And,
That's a good catch.
thank you, Adam.
Okay, thank you.
Yes, Barbara.
Is there something in this website that's going to tell you what to look for? I mean,
I would say not at this juncture, because this is a test, and you will be the only people who see it, and other people who are invited. It'll be password protected. I think what we're going for now, before we try to go into any kind of a production mode, is to see what columns and rows you would like to see, because that's where the intense data building is.
but I think that's related to telling people what it is that they need to look for.
Well, that's true, and I would say if you think of this site, it's not the consumer site, this is the industry site, this is our supplement to the physician pricing mandate that we have from the legislature, report information on pricing. So in a report, we can't give you lots of detail without having the pages be very long or you sort of falling asleep. So here, this is a supplement for physician pricing, and yes, I think that there will be information about, probably the same kinds of information that CMS provided when they gave you the data, which is not very much, which is these are the prices by CPT code. I mean, this is probably not a table anyone who doesn't know what CPT means wants to be looking at. And so I think there will be some supplemental information, but again, remember, this is sort of in line with what the legislature told us to do, pricing information, and it's not, this would never be a place you would send a consumer to have fun,
No, I mean, but this is going to be, then everybody, whatever industry is looking at this, is going to be using their own standards to make their own judgments about the information.
Yeah.
Right.
I think as with CMS, we're wanting to make the data accessible, and people will use it based on their needs.
Yeah.
We can show you that next week. We wanted to show you this first because we showed it last time, and when you could only search on the provider name. So we haven't searched on provider name because we showed you that last time, but this time we've added that you can search on procedure groupings so that you could see, if you wanted a cabbage, who are the physicians who do them and how many do they do. Now that's an example that might be amenable to a consumer, but just in general, so if you go to the, what was your second one, the cancer chemotherapy?
So I'm on cancer chemotherapy right now, and I just wanted to make the point of the change in the procedure view. The first provider here, you're only seeing the procedure that's related to this procedure grouping. But if I were to clear my selections and search on that same provider, I would get all the procedures for that provider. So playing with this, you will become, one, more familiar with how it's working, but more importantly, how you want to work with the data, how you want to slice and dice this presentation, and that's the information we are soliciting from you.
Yes, Barb.
Then to follow up, do you also show their affiliation, as they are, whether whose network they're in, or?
No. There's none of that consumer information. Strictly pricing. There's no. I mean, I would say.
I only meant to sometimes if somebody's a member of a more robust network, they might have more volume. You know.
That's really true. But this is probably across all their. This would be across all their private patients and their Medicare patients. So it's unrestricted, but it's only Maryland residents. So you see what work they do with Maryland residents here, because we don't have the universe.
So if somebody's on the border, they could appear to not have that many procedures, but they really do, but they're not Maryland residents.
That would, in fact, be true, and that's part of the caveats that, you know, in terms of the data limitations, our data, our private data really only captures Maryland residents. So that's one of our limitations. And CP and Medicare also, when they did theirs, limited the procedures based on the residents.
One other thing I wanted to point out is that for the purposes of getting this demonstration together, one specialty is attributed to the NPI and one location, but we know in reality, practitioners have many locations typically and many specialties. So these are data challenges that we have to overcome and find other data sources and also improve our own data collection so that we're actually working with the payers to improve the data we get so that this information is more reliable for matching purposes to get more robust presentation in terms of being able to look across locations, look across specialties, etc. So, and also,
Maybe you could show the provider portal, given we're trying to stay on schedule.
okay. You mean the procedure?
For procedure.
Okay. All right. Shoot. Over here.
Okay.
Oh, that's right. Okay.
So what I wanted to tell you about this procedure search track is that it's under development. We fleshed out the provider one more. This one is under development, has some view options that we're interested in getting feedback on, particularly in how, because you're sophisticated users, do you want to see means or do you want to see distribution? So for example, we picked just two to look at today under the procedure list. So this is the established patient office visit, 15 minutes, which is a very common visit. And if you go, if you go all the way to the right, you can see the Medicare data columns. And if you look down at the far column that says, okay, so if you look at the far column which says allow mean, it's the mean allowed amount. You'll see some variation, and these are actually Medicare payment regions. So if you look down at the national capital area, those are the highest allowed, and that is the highest payment rate in Baltimore, are those two counties for Medicare. And then the second tier is the Baltimore metro region, which you can see is 74, 75. And then the entire remainder of the state is the lowest Medicare payment region. So if you look down at the bottom and you see Garrett and Washington, you see it's 71, 72. Those accurately reflect the differentials that Medicare pays across Maryland. And those differentials are based on the costs of providing services in the region. So if rents are higher, reimbursements will be higher. And then so what we've shown there are means, because that's the way Medicare gave us the data. If you look over at the private, you'll see that what we have are allowed amounts, but we have a distribution there. The 50th percentile is your typical allowed amount. It's the median. And then we show the 25th and the 75th percentile. And you can see that the allowed means are, if you look at the typical mean, it's a little lower than a mean would be. But even so, you can see the 75th percentile is a little up at the top. The allowed amount is sort of still a little under the Medicare allowed amount. So for this particular procedure, the private payers pay a little less. At the allowed amounts are less. We're going to look at one where they're more. But the question is, would you rather just have one mean, or would you rather have a distribution? With the 50th and the 25th and the 75th. This is about sort of how much detail. And then also you can see that it shows the reimbursed amount Medicare gave us in their data tables, which is what Medicare pays. But there's the difference between the allowed mean and the reimbursement mean is what the patient paid. So the patient out-of-pocket wasn't part of the Medicare table, so it happens to not be here. But if you look over under the private at where it says PAT LIAB, which is patient liability, and so you can see under the 50th, the 50, which means median, you can see the typical patient liability for an office visit, which runs $20, $15 and $20 is the typical liability. At the 75th percentile, it's as much as $25 or $30, so you can see that on the table. So one of the questions is it nice to have the patient liability column? And would you also want that in a mean or just the 50th percentile, which is typical, or the range? And then we also, for the private, because we've included the reimbursement, we have, and that's the carrier reimbursement. So you can see under reimbursement, that's just the carrier portion of the bill. So you can see that typically the private insurer in Anne Arundel will reimburse $44, whereas Medicare reimbursed like $53, so a little bit more. So you can get a lot of detail out of this table if you're so inclined. And so the next one we're going to look at is a physical therapy visit. It's 15 minutes worth of PT. There we go.
While you're doing that, do you want any answers to your questions?
Oh, yeah. If I'll, so.
The one thought I have on this is you're going to always have a perspective that some audiences want more.
True.
So
true.
And then some audiences want less. And what I found really useful on the website is to, just think about the double-click methodology. So if all you did was show means, then if you could click on that mean, you could then get a distribution. Then you'll satisfy both audiences. But I think what you'll find on the websites is that if you put too much information there, it'll lose its impact.
Yes.
But by with today's technology, you can really if you get the hierarchy right, you can satisfy both. So for what it's worth, that's my perspective.
So here, just to show this also shows you that more than physicians are in the data, as long as they, in this particular test data, as long as they see Medicare patients. So this is 15 minutes of physical therapy. You can see if we compare the Medicare allowed column to the private insurer allowed column, you can see that, again, boy, this is hard to see, I'm sorry. The difference in the allowed amounts between the two carriers, you can see the same pattern, the geographic pattern in the Medicare allowed means. That shows, again, the highest payment rates are in Metro DC. And you can see that here, at least in 2012, the typical patient liability for 15 minutes of physical therapy was no copayment. However, if you look at the 75th percentile, you can see that there are $10 or $20 copayments for this 15 minutes, and you can get an idea of just how much physical therapy there is. So I just wanted to show you that organization so that you could give us feedback on your preference, and I do really like the idea of the double click, which is really good. So next, can we do the next slide? He said to just close the browser, he said. There we go. So we need to go to the next slide. Again, there we go. So we are requesting feedback. We got good feedback already today, but again, the focus here is we're trying to keep it pretty narrow, that this pricing app will replace to some extent or supplement the current professional services report so that people can, investigate prices to their heart's content. It's this information is sort of more timely. We're looking to have the information be more timely and detailed and consistent with our mandate to report information on pricing for professional services. That is the mandate. And we would like you to give us suggestions on what you think the presentation should look like, just we got some today, for both the provider search and results tables, which are a little more fleshed out, the procedure search and results tables, which are not, but ask you to say, how much information do you want? One of the things you'll notice is there's billed information in there. And my question is, do you care about bill? Do you think most people care about bill? Does it need to be there at all? Because we do want to limit some things. And then we do need, as we were talking, as the chairman mentioned, we need to balance sort of ease of use with the amount of information displayed. And we do want to remind you that for this little app, it may have to stay sort of, it may not get all the way to graduate school because we are doing it in-house, and we need to keep it sort of lean and mean, with the emphasis on lean and maybe not so mean. But that this is a nice additional tool. It's not probably going to have all the bells and whistles that you would like, but it's within our budget and our mandate. And so we need to be able to do that. And another thing just to consider, because of all the depth of the data, one thing that we are asking you to contemplate and get back to us on is not all the information that someone would want even can be displayed. It would take way too many data tables. And Medicare has made available their summary data tables, which you can download and look at. And the question is, how does Commission feel about us making summary data tables, similar to the Medicare data tables, from the privately insured data available for people to download and peruse? So that's something to consider.
So maybe we can cover the next step.
Yes. Oh, yeah, right. Next slide. So next steps is that next week we will be sending out emails to commissioners and to members of the Practitioner Performance Measurement Work Group, a location where the apps can be accessed, and there'll be a password. It's not that it's private, it's just that because it's a data subset, the last thing you want to see is anyone publishing information that they got from here in the sun, because it won't be accurate. This is a test mode. You'll be giving us feedback. We'll be developing the pricing application version 3, adding new features and incorporating your feedback into that. In June, we'll come back with a new version in 3 to show you in July. Then we'll be making additional revisions, and hopefully we'll get to the place where you all feel comfortable with something that when we say public, again, I don't mean consumer, I mean industry. And then we can migrate this pricing application then into a production site. And what I would say is the changes need to be made before we go to the production, because that's when it becomes really expensive to make changes. So we'd really like to spend some time, having something. It's not going to be the world, but it can be helpful and useful, and that we can put on our site. And this would be the first of several initiatives like this, where we make more detailed data available to industry representatives right on the website.
Just as a point of clarification, somebody still could go through an IRB and get all your data anytime they want, right?
Yeah.
So that process doesn't go away. This is just an improvement.
Right, and
it's just something to help market that. Actually.
Right, and this would correct, and this would has the added feature that it's summarized in some way that it's already has a conceived view as opposed to you get millions and millions of records.
Yeah, and just very briefly, an IRB process, the applicant would have to demonstrate the need and the benefit exceeds the potential risk. So it couldn't be just anybody.
Are there questions or comments?
So by early next week, we'll be sending you a password and a link to the site. The site's on an internally now. It will be on a password-protected web location for the testers. I think the last point I would make is that with an industry application, some consumers would have access to it at stage 4 when it's public, but we're realizing that it would be what we have today is incomplete or a full consumer assessment location. That's yet to come.
One question I have is on the strategy here. If you look at analogs in healthcare and other places, the people have made deliberate choices about how they want people to use their data and whether they want them to have sort of full ability to aggregate it, recut it, mash it up, what have you. What's our perspective around trying to make that easy for other stakeholders, to take a different look at the data than how we're presenting it?
I think that what happens with any complicated data set is whoever's website you go, the website can only give you limited views. And if you want to slice it and dice it other ways, then you really do need to get the data. I think there are limited ways that you can slice and dice it because they're infinite. So you have to pick yours. And so I think we would say that as long as those views don't have too many data tables, then we can slice and dice it. But once it starts to get really onerous, then it becomes more efficient to do programming and get the detailed data. I don't know if that was the question you were, did you mean something?
Well, it sounds like you're not adverse to it as long as they're not technical barriers. I read that.
Correct. Yes, I would say, yes.
All right, thank you.
On the budgetary barriers.
I think that's true.
That's a big one.
That may be more overriding, yes, than the technical.
Well, maybe it's just me. And so I was at this leading age conference a couple weeks ago, which is Long-Term Care Association, and they went through the national quality metrics that they had there. It was a 2-hour presentation, and the guy was a techie, and he knew what he was talking about, and he explained to all of us, took us through data collection to compare nursing homes and the different quality metrics. And you could follow it when it was there. When you go back, you didn't even know where to begin again. I go back to my office, couldn't. So I wonder if, and not to make more work, maybe it's just me, if you could put in some flow charts just for how to get to a couple of key things.
Right. I think that's an excellent thought. And I also neglected to mention that we will be conducting a webinar. We'll probably only have one. We'll send it out where we, again, it'll be principally what you saw. But you're right that there's wonderful for some directions because once the webinar is over, you won't remember. And so whether we put the directions in the email or we actually include them sort of like the button, which was the caveats, that may be the safer way to do it. We'll include that as well. Thank you very much.
Thank you. Thank you very much. Last item is Advanced Directive Registry. David Sharp and Sarah Orth are joined by Ryan Bramble, Program Manager at CRISP, and Jeff Zucker, CEO of AD Vault. They'll provide a demonstration of an online Advanced Directory Registry integrated with the CRISP Query Portal.
So good afternoon again, Mr. Chairman, members of the Commission. So you can see our panel, a short one name. We have joining us on the phone is Jeff Zucker, who is remote. So hopefully, Jeff, you can hear us and you're able to communicate back with us at this point in time.
I can.
Wonderful. We're really excited to demonstrate a technology which, after you see it, you're going to think, well, this doesn't seem all that. It seems very simple. But it takes a lot of lift to bring together technology and work in this fashion. So if it looks simple to you, then we've done it right, if you will. So just to frame it up a little bit, we're talking about advanced directives, and most everyone knows what advanced directives are, but in short, they enable individuals to identify what action should be taken for their health if they are no longer able to work to make decisions because of illness or they're incapacitated. Making advanced directives available electronically as part of a patient's health record can help to ensure that this information is available at the time and place of care. Putting a platform to share medical intervention information will enable healthcare providers to render more patient-centered care, and using the statewide HIE to bring these two touch points together seemed like a logical fit. The registry that you are going to demonstrate will allow all Marylanders to create and maintain advanced directives online using a product called My Directives, and it will be viewable to any physician, any clinician that participates in the CRIS statewide designated HIE. Today we're looking for feedback from the Commission on the solution, and pending the feedback we receive will impact the release date. Tentatively, we're planning to release it around the 1st of June. The rollout strategy is fairly broad. We're working with almost all the stakeholders, the Maryland Hospital Association, MedChi, Lifespan, MGMA, and CRIS, and various other stakeholders to help communicate the availability of this solution and educate the community about advanced directives. So with that, I'll sort of pass it down the line a little bit.
Thank you, David. Good afternoon, Mr. Chair and Commissioners. Well, state law has allowed the Department of Health and Mental Hygiene to establish a statewide advanced directives registry. Since 2007, funding for that registry has now been made available. In 2011, the MHCC received a long-term care challenge grant from the Federal Office of the National Coordinator for Health Information Technology. And one of the components of that grant was to develop recommendations for a framework to store and exchange advanced directives. The MHCC convened a focus group in 2012 to deliberate on the technical and policy challenges of a registry for advanced directives as well as MOLST forms. And the focus group recommended that if we create these registries, that they be made available through the state-designated health information exchange. In 2013, the ONC approved use of some of that challenge grant funding to establish and implement the registry, and the MHCC was awarded additional funding through DHMH for this registry. The MHCC released an emergency request for proposal in October 2013 to procure services for the establishment of the Advanced Directives Registry. AD Vault, which is the vendor for mydirectives.com, was competitively selected to integrate its existing electronic Advanced Directive Registry solution into CRIS. At this point, I'll turn it over to Ryan Bramble to demonstrate the process of retrieving an advanced directive available through mydirectives.com. And after that, we'll hear from Jeff Zucker and watch a video about the AD Vault solution. And at the end of the demonstration, we will welcome and seek Commissioner feedback on the technology.
Thank you, everyone, for allowing me to be here to demonstrate this technology. What I'm going to do is go into our test site here and show you exactly how it works. I'm also going to give you a brief overview for those of you who haven't seen the CRIS query portal in general and some of the data that's available there and how you get from there to the advanced directive. So I will log in here into the test environment. So just give me a second. All right, so this screen here is where the providers land when they first log in. It's basically a query page. It's asking you to provide either last name and date of birth or the medical record number of your facility to go out and see medical records for the patient you're currently treating. I'm going to pull up our test patient, and all the data you'll see here is fake data. These aren't real patients, so nothing to worry about there. When I do that first search, I'm going to get a list of potential candidate matches based on that information. If there are someone with a close name or a close address to this, we'll actually give you more than one to choose from so you can make sure you pick the right patient. When you do pick the right patient, you'll click on the name there, and you'll get to our summary screen. And I apologize if this is small on the screen here. I'll try and read out as much of it as I can. But basically, when you do a query on a patient, you get 4 pieces of critical information. You get all the lab work that's in CRISP, all the radiology reports. It's not pictures yet, it's not images yet, it's just the impression of the radiologist. You'll get documents that are transcribed, so this is where your discharge summaries or your history and physical would be, consults, all those different things would be here. And then you get medications, which right now come from the Maryland Prescription Drug Monitoring Program. So back in December, the state authorized CRISP to be the place where providers and prescribers go and dispensers go to see all of the Schedule 2 through 5 drugs that get dispensed in Maryland. And this is very close to real time, depending on the technical capability of the pharmacy. But basically, you can be pretty confident that any Schedule 2 through 5 drug that gets dispensed in Maryland will be in this list here. Those are the key boxes of information that you have access to. Now, over here on the left, we have a whole bunch of features. And some of these features are to download summaries of care, PDFs, CCDs, things you can attach directly into your EMR. We're building the technology to send things to other providers via encrypted email, direct messaging. We're adding SureScripts capability soon to get some of the other drugs that aren't part of the prescription drug monitoring program. And then, as you can see here, we have the button to request an advanced directive. So if I wanted to see Jenny's advanced directive, I would just click that button. We get a pop-up here now. We're working to streamline this a little bit, but basically we have an information box here to let you know that we're going out to My Directives to get this, that this is a final signed directive, that the patient has done this on their site. We're only going to return directives that are signed on that site so that we're sure they're the final, most recent signed directive. And then you're going to click this button. Right now it's going out to AD Vault to see if there's a directive on Jenny Rollins, and then it will return either click to view or there isn't, and I'll show you in a minute what it looks like if there isn't. If there is a directive, you just click to view. That's going to pop up a new window where we're actually now loading from the My Directives site in another window. And just waiting on the site to return. What I've found is that in the test system so far, the first one takes about 10 seconds, but after that it's quicker, so we're working to improve the speed there. But this is the directive, so it's a summary that you can just pull up here to read through. We created this one the other day. It came available quickly in real time, essentially. You can print this, and there's a bunch of other actions you can take as the provider reviewing this directive. So I'll scroll down through this slowly so you can just take a look at it. And Jeff, I'm sure, will speak to more information about My Directives and the types of things they capture and how it works. Okay, and I can hop back over to CRISP. I will show you just really quickly what it looks like if a patient is not found, or if a directive is not found. Get a different patient here to look up. I seem to have lost my keyboard. Oh, there we go. Okay, so Della Bailey here does not have a directive. When I click the Get Directives button for her, you'll see that no advanced directives are found for this patient. Now, this is just phase one. Phase two, we're going to make it easier for the provider to then get the patient to sign up and get a directive, perhaps by putting an email box here that they can put in the patient's email address, and My Directives can email them and ask them to create a directive. Or we can potentially send some of the demographic information that's already in CRISP over to My Directives to get them to reach out and see if they can get a directive created for the patient. So that's the technology piece of this. I'll turn it back over to Sarah.
Thank you, Ryan. And we're back.
Glenn.
Mr. Chairman. So on the, if Della Bailey, if there's more than one Della Bailey on the other site, does it return other matches as well?
So right now, it's only going to return one-to-one matches. The second phase is to work through the integration of our master person index and their person index if there's potentially a conflict or a duplicate over there.
So if there is a potential conflict, what would happen?
Right now, it would say there's no directive found if there's a potential conflict.
Gotcha. Thank you. We like to think the MPI is fairly robust in that we won't be faced with many of those types of challenges.
I have a couple of questions. And this may be some background that I missed, so I apologize. If I were in the state of Maryland and I was in the military, retired military, and I had an advance directive developed through that legal infrastructure, would that be able to be included? Likewise from another state?
So today, what you're seeing is limited to this solution, but there is a way to bring it in, and we can ask Jeff to talk a little bit about that. If you allow us to hold on answering that question for a few more minutes.
You want my second question?
Sure.
Is there any way, and this may be thinking about it in a very different context, when I looked at it, if I set up my advanced directives and I knew it was in the system and that it had to have some standardization in order for it to be retrievable in the system, and I may be making assumptions that don't exist about standardization, is there any way that I can see my own directives in context of this system? Have you thought about that?
So I think the question is, can the individual who creates the directive have access to it? So just to point out, these directives are primarily consumer-driven. So it would, the information that you'll see in a moment, plus it's available through Chris, is developed by the individual. So while a physician, a clinician could, a nurse practitioner could spearhead the initiative, ultimately it's controlled by either the individual or their delegate, an individual that acting on their behalf.
The example you showed was very, very specific around certain conditions and situations, and legally there are at least two, there could be many more, trains of thought about advanced directives being much more, when they're written, allowing for less specificity than what you had, and I don't know how this system would handle that. So that was why I would want to see that if I were the, recently having gone through this, legally there's some, and that's again, it's a very personal preference, but there is, I've seen advanced directives clinically that are extremely specific, and I have seen them that really aggregate conditions very, very broadly. And I was wondering how this system would adapt to that, and that's why I would want to see it.
Yeah. So, Jeff, when you start through, after the video shows in the demonstration process, would you mind answering Dr. Montgomery's question? I think seeing the video will help provide a little bit of context as the question is answered. That's a good question.
Yeah, if I could just add, I actually went on and did this. I did my advanced directives on there, and it took like 15 minutes, and you could do as much detail, as highly clinical or as less clinical as you want. It was pretty simple, and you could download your little flash drive with you or email it to my wife, whatever. So anyway, just an FYI, I actually did it, and it was very interesting.
Oh, thank you. Yeah. Feedback.
My question has to do with the access of this to pre-hospital first responders, not only for advanced directives, but also you can comment really quickly on DNR orders and organ donations. Direct.
Yeah, these are great questions, and we've thought about them a lot already. And we started out of the gate small, predominantly because it was a funding matter, not a brainstorming or for any other reason other than we just had limited funds. But we absolutely would like to get there next. In fact, we're already talking about some strategies to incorporate MOLS in this process. So we will get there. It's just how we can get there.